morning, ladies and gentlemen. It's now 9:30, so time for us to start our meeting. And Happy New Year to all of you whom I haven't been able to say that to already. I think you can still just about get away with that by the end of this week. After next week, we're well and truly into 2020. For those of you who are familiar with the way the Trust conducts its business, our first item is feedback from something that we call 15 Steps, which is basically groups of us, well, usually couples of us actually, or perhaps small groups of three, going out into various parts of the hospital, talking to patients and staff, getting feedback, observing what's happening. And we feed it back formally to board colleagues so that there is a proper record and that we can be sure that we're picking up things that need addressing. We do have to go through it fairly rapidly because there were 6 groups and time is limited. So everyone's got about 2 minutes each. And when I start frowning, it means people have been talking for too long. So hopefully there'll be no frowning. And I'm going to start with the group that went to medical records with Daniel, Debbie and Elizabeth. Who's feeding back? Elizabeth, over to you.
It's one of the great, they are the great unsung heroes of the hospital because we have 700,000 outpatient appointments every year, and each one of those outpatient appointments needs to have the record, the file with it. And these are the people who do it. They are an extremely dedicated group of people. They walk around the libraries something like 18,000 steps a day. So if anybody wants to get their steps up, I recommend you go and do a short secondment down there. And their dedication and attention to detail was amazing. And it was really great fun to go and see them.
Fantastic. Is that it?
Well, you said 2 minutes, Chair.
But you only had 1 minute.
Okay, well, Daniel, would you like the other minute?
Well, I took a photo of Elizabeth and Debbie with Alan, who's the medical records deputy manager, with their new toy. And their new toy is kind of like a converted milk float, but an electric-powered vehicle for moving outpatient records around this site, because now we've moved outpatients to Woodcote Wing, most of them. You have to go outside, and the existing trolleys weren't good enough. So they commissioned a specially built electric-powered float. It looks amazing. There you go.
And they're pleased with it.
Delighted.
Excellent. Okay, that's great to hear. And as you say, Elizabeth, they're a vital part of the hospital working properly, actually. So that takes us on to the pharmacy. And Aruna, it was your group who went there. I don't know who's feeding back.
I'm going to start.
So, over to you.
So first minute from me. We went to the pharmacy department, which is also down in the basement. Really interesting visit. Very busy team down there. We observed them doing a 9 o'clock huddle where they were looking at what they'd done yesterday, what went wrong, and what their forward planning was going to look like for today. We saw how a TTO, which is a tablet to take home, was tracked through the system, and what the challenges are of actually managing the tablets to take home process is. So some of the things they raised with us were delays in doctors getting drugs to them, the lack of automation down in pharmacy. It's a very manual process and lots of people involved in dispensing the drugs, and a lot of checking that goes on. We saw that the staff, I think, were very happy. I talked to 2 or 3 staff down there, really happy new staff, really happy staff who'd been there for a while. They felt very supported by their manager. They had a great information hub for GPs and for hospital staff where people can phone in and get advice about pharmacy. And what else did we see? I think that was some of the main things that I picked up. But Aruna, you might have something to add, or Thurza?
So I think real opportunity for automation in this area. I mean, it really struck me how manual everything is. And I think what my big takeaway was, do we have an opportunity here to step back and say, in the new world, what would this ideally look like, and what can we do? Is there some low-hanging fruit that we could address straight away? Because, I mean, simple stuff like, doctors not putting discharge dates on the TTOs. I mean, these guys are working consistently until 6:15 every day. That can't be right, because really everything comes in at 4 o'clock and it doesn't have a discharge date. So if it had a discharge date, they don't necessarily have to finish it that day. So I think there's some low-hanging fruit there, but I think there's an opportunity to step back and look at what we can do in the big picture. Teresa?
Can that point about discharge dates be picked up? Because I've heard it at George's as well, and it just does help if doctors can be reminded to put it in. It makes pharmacy's life easier. So.
Yes. I mean, I just wonder why it couldn't be a mandatory field, but apparently there are reasons for
I've
that.
I've looked
Yeah,
at it with some of the junior
exactly.
doctors, and there's an issue with the electronic form around the field there, so we do need to look at it.
Yeah, okay, that's great.
Thank you.
Thank you. So that takes us on to Pat, your group. You went to decontamination.
Yes,
Sterile services, yeah?
Peter and Arlene and I went to decontamination services, which is again a perhaps disregarded but fantastically important part of the hospital's function. But it is run for us by Steris. The first thing to say is the environment is pretty awful. I don't think any one of the three of us would want to work there. It feels very oppressive. There's a very low ceiling. There's absolutely no natural light. And the relaxation, if we can call it, areas for the staff who work very intensively are poor. But they do say that they do get good response when things actually go wrong from the estates. And they're very, very cheerful folk, very positive about what they do, which they clearly recognise, and you couldn't fail to, because it's such a complex process of sterilising instruments that come from theatre. You couldn't fail to be aware of how important the job is. And it was a fascinating visit because it shows you all, we saw all the stages. Indeed, we dressed up in very attractive outfits in order to look at the way it worked. And we were genuinely really impressed with the dedication and the positive attitude of the staff.
Does the unit have accreditation? There's an accreditation scheme, isn't there, for sterile decontamination and sterile services? Yeah, and it's audited regularly, isn't it?
Annually.
Yeah. Yeah, and we've never had any problems through that process, Trevor.
So we do have problems in terms of the ventilation, and that's part of the work that we've done in terms of actually providing a new fit-for-purpose facility. And it's planning to, in 2020, to move off-site to a warehouse in Chesington.
Did you want me to come in on that?
Well, so we did a joint procurement with. Started off with Kingston,
Yeah.
then it went to just be us, and now we're back with a shared partnership with Kingston for it,
Right.
which is why it's going to be in Chesington.
Chessington.
And so it's in between the two
Yeah.
hospitals.
Yeah, okay. So, Martin, you went to the Urology Unit with James and Rakesh.
Yes,
Martin,
and
there you go.
the Urology Unit was, for all of the ones that I've done, that I've visited, this was by far the most positive. And I think it reflects that there are certain basic things, if you can get right, it makes such a big difference. So first of all, the physical environment was really nicely presented, really good sort of quality of standard of accommodation, including the staff room, the staff facilities. The level of staffing was right. They had problems before, but the recruitment had taken place, and I asked about the support they'd had to do that recruitment, and that was positive. And then, of course, it's also about the teamwork, and they clearly worked very well as a team. We did actually struggle to get them to say anything in terms of what they would like improved, and we ended up with two things. One, the receptionist, rather an old computer, so the time it takes to process, particularly to print, where patients are waiting, was one. And the other one, in a kind of, I suppose, a part of the success really, just more clinics, by which they mean more space to run dedicated clinics. But I don't know if James or Rakesh want to add anything.
I might just add a couple of things. It was a very uplifting experience for me, and often I report back that the physical environment is extremely challenging, but the teams are working well. I think that it felt clean, it felt fresh, it was a welcoming physical environment to receive care. It was a really happy team, and for me there was a sense of opportunity, a sense of great teamwork across the different professional groups, and they recognised that they still had more that they wanted to develop, but they sensed that they understood what they needed to do in order to achieve their vision. So a really, really positive visit.
Sound to me like an early candidate for QI. Right, so that takes... Ruth, you and I But you're going to talk, aren't you? Because if you don't mind, because otherwise, I don't think chairman should carry on talking in meetings.
So,
I don't need any encouragement.
so thank you.
Use that against me.
So Gillian and I, we visited Gloucester Ward, which is the inpatient ward with a focus on people with respiratory conditions on this site. I think in terms of the sort of physical layout of the ward, it's well kept. The boards are up to date, but clearly, as we always say, there is a lot of equipment needed on that ward that cannot be stored securely and that's cluttering up corridors. So they are challenged with the environment. We spoke to staff, we spoke to patients. They'd had a very busy night there with patients requiring or deteriorating acutely overnight and had coped with that really well. The issues that came through from the ward were that the therapists wanted to highlight their concerns about lack of pay parity in the context of London waitings. They enjoy their job, they enjoy being part of an MDT, but they're concerned that this requires resolution, and there were ongoing conversations about that, which we said we would feed into. The staff there generally were very positive. We spoke to a patient a young patient who'd been on the ward for 3 weeks with an acute respiratory condition, who could not fault the care on the ward and said that was in contrast to when she'd previously been admitted to a general medical ward. She really saw the benefits of being on a ward that had a focus on respiratory conditions. And we asked if there's anything she'd like the team to do differently, and she couldn't actually think of anything except to try and see that the right ward was used for the right patients.
But she completely understood that often, particularly in winter, pressures meant we couldn't always get people quickly to the right ward. So, and she'd had a really tough Christmas, hadn't she? She was, in fact, they hadn't had Christmas. She was hoping to get home at the weekend and have her Christmas. So she was jolly cheerful despite all of that. Ruth. So that, last but by no means least, takes us to Chris and Trevor, who went to Swift Ward. Who's? Chris, hi.
So we went to Northier and Swift Ward, which are interesting wards because they get used when the hospital is busy with emergency admissions. So they're not, as you were describing there, a respiratory ward. They have to take patients with a wide range of the conditions. We went first of all to Swift Ward, which is a day surgery unit, though it does have, patients do stay there overnight if they're either slow to recover from their day surgery or if they need to be admitted the day before for some preparation treatment. The environment of the ward was very good. They were very pleased with their new floor, which did look very good and smart. Everything, all the trolleys and all that sort of stuff was well organised. It all looked neat. The staff were well organised. They were having to move some beds around from one room to another because they had an unusually large number of male patients being admitted that day, and that meant doing some shifting around, but they weren't, they accepted this as the normal thing you have to do. You can't have exactly half women, half men being admitted every day to keep it neat and tidy. So that was very good. Moved on to Northie Ward, where that again was neat and tidy. All the cupboards were properly locked, all the equipment was properly stored and so on. I thought the decoration wasn't quite as up to scratch as it had been on Swift Ward. I talked to one of the patients, an NHS patient, Northie Ward is a mixture of private and NHS patients. It was about 50-50 today. I talked to one of the NHS patients who was very complimentary about the treatment they've received, very happy. Particularly wanted to praise an individual who was an HCA working on CCU, yes, before this patient was transferred up to Northie Ward for the care that this gentleman had given. But very happy with everything. Both wards, importantly, said they had good connection, could easily get hold of medical staff when they needed input from doctors, because that's always a slight risk when patients aren't on their proper ward. So that was good. The patient, there's a slight comment that they're waiting. He's waiting for an echocardiogram, which I know is always a bit of an issue. He can go home as soon as he's had his echocardiogram, but there's no specific date other than soon for that. So that would be good. I mean, it's good for the hospital if he can go home, even better for him if he can go home. And they did comment on the shortage of blankets when he was in A&E. Couple of weeks ago. Apparently it was a black alert day and the cupboards were bare of blankets. So maybe those things to think about, but they were very complimentary about the standard of care, both in clinical terms, but also that patient relationship with staff. So I think unless Trevor wants to add anything, that's...
No, I think the only thing for me on Swiftwall was the issue with their drug fridge that's been out of action, out of order for like 3 or 4 weeks and still not being resolved, so we'll pick that up.
Yeah.
And that blanket point, I'm sure it was a product of being in Opal 3, or 4 even, was it? Yeah, okay. Thanks, Sue. Right, we just about got there. We were a minute over, but that's not bad because we've had 6 lots of feedback. So we're going to, we would have moved on to our patient story, but unfortunately, the person who was coming to talk to us about her experience of maternity services has had a bit of a crisis and can't be with us today. So we will put that to our next meeting, I think.
Yes, Chairman, she's confirmed that she'd be delighted to come to the next one and she apologises profusely.
These things happen, and she was doing us the favour anyway, so it does mean we've got a little bit of time in hand as well. So I'm going to move on then to item 3. I've already done the welcome. We've got apologies from Richard Noble, who's somewhere in the Antarctic at the moment, I think. Well, in some ways lucky, but it's probably cold. And Derek McCallan has also given his apologies, and Philippa Jones. But I think Philippa and Sue, you're going to alternate, aren't you? So, yes. So I think it's not so much that we've got Philippa's apologies as it's not her time for being here. Yeah, but I think it's important that people understand that. Thanks. Any declarations of interest? No? Okay. Minutes of the previous meeting. Could we agree those minutes? Yes. Thank you. Actions from the previous meeting. There's just a couple of points. They seem to me to be fine, unless anyone's got any problems. Can we note those? Thank you. And then in terms of my own update, really all I want to say is that I think I've been chairman now for just about 3 months. It's been an incredibly enjoyable and busy 3 months. And the thing that I really wanted to kind of report, I think, to full board is the warmth of the welcome from staff and partners alike, which has been so encouraging. And also being able to get out and meet so many of our staff in their workplace and see them caring for patients and the fabulous work they do. So I've been out and about in quite a lot of places in a short space of time. And I think out of all of those, I'd probably mention my visit to the Croft Unit when we had an official opening, and it was fantastic. The work that's going on there, I think, in terms of the offer that we're able to make to our communities and our patients is absolutely wonderful. And of course, now I'm trying to talk to Georges about the same kind of thing, and as you all know, sometimes it's annoying when I talk to you about Georges. I think sometimes they get annoyed when I talk to them about all the fantastic things that are happening here. And I think the only other thing I wanted to say, I'm sure Daniel will say it in his report, is just how hard staff are working at the moment and just how busy the hospital is. Really, people are going above and beyond every minute of every day, and I think it's really important that we all, that they understand that the board doesn't take that for granted for a minute, and how grateful we are to them for carrying on doing that day in, day out. As some of us know, because we've had the flu, despite our flu jabs, it's been very debilitating for those who've had their jabs when the virus has got through, and that has no doubt contributed to a lot of the very poorly people that we've had coming to both hospitals. But I know that we're doing our very best to look after them as well as we can and get them home as soon as they're able to be there. So that's all from me. I'm going to move on to 3.6 and Daniel's report to the board. Daniel.
Thank you, Gillian. So the three things I think to bring out in the report to the board. So the first one is to pick up from where you just left off, which is, so this is a very, very hard winter for the NHS. So the data that was published yesterday about A&E performance nationally, the hospital data showed that hospitals delivered only 68% of patients within 4 hours. We delivered 82% of patients within 4 hours, so still quite a long way off the 95%, but we are
long way ahead of others.
But certainly doing much better than the average, and that's down to the sheer amazing people we have working in Epsom and Helier. So a massive thank you, and also to all the partner organisations we work with. So in some of the most challenging times we have had a superb response from GPs, from the London Borough of Sutton, the London Borough of Merton, Surrey County Council, and everyone has really stepped up. So on a slightly lighter note, on Christmas Day I went round St Helier, and you can see in the report there was a lot of festive jollity going on amongst it being very busy everywhere. And on New Year's Eve I did the same thing in Epsom, and I think I got to every single department in Epsom on New Year's Eve, including places like medical records. And just to give you an idea about how busy it has been, on New Year's Day and January the 2nd, between the two hospitals we had 250 ambulance arrivals and we admitted 200 people. And that's extraordinary volumes of sick people, and everyone's done amazingly. So the first thing was to echo yours, a big thank you.
Sorry, I didn't mean to steal your thunder, Daniel.
No, it's
better to say it twice.
Exactly. So then the second thing is, well, we thought it'd be quite a neat idea to do a review of what happened in the year 2019 in Epsom and St Helier, mostly in pictures, so you can see a little montage for each month. And I was just wondering how to talk to this without taking up a very long time. So I won't. Which you don't want. So I thought there were two themes that come out of all the pictures. So a huge amount about our people and amazing things that they have done, and also a huge amount about our buildings, which are continuing to go through a massive renaissance of investment. So if you just focus on the people things rather than the building things, in January, I think the people story is about us launching our book of respect and setting out what our staff can expect from leaders and what we should be able to expect from staff. In February, I'd say the people story is winning the contract to provide sexual health services in Sutton back from Chelsea and Westminster and doing it in an integrated way. That has been a massive success story since that then started. Big improvements in care. In March, I'd say the people story relates to stroke and the stroke team delivering the highest possible quality standards. In April, I think the story is welcoming 1,000 community staff as Surrey Downs Health and Care and Sutton Health and Care massively expanded. There's so much more we can do in integrating the hospital and community, but having the ability to do it on a big scale now is fantastic. Can I do one for each month, or do I need to?
No, it's all right. We're all right time-wise.
Right.
Yeah. You'll begin to feel the vibes.
Okay. Right. So in May, I think we had these huge welcome events where we brought all of those new staff and our staff together. In June, well, this is an estates and a people story, but we started building Mole Valley Building, which is the new building at the front, which is a fantastic building where all our admin staff can actually work together properly in an open plan environment with the right technology, which has been a massive step forward for them. In July, the people story is really about patient transport. So we brought that back from the private sector and we inherited this complete rag bag of ancient vehicles. And we have replaced them with 48 brand new ambulances. And I hope you've seen them driving around all saying Epsom and Helier, and as much about recruitment as it turns out as about patient transport. But patient transport is in a much, much better place now and delivering its quality standards. August, I think the people story is the beginning of All Systems Go. So we are finding a new way of bringing all the different parts of the hospital together and all our partners together in a concerted effort over a period of time to ensure that we can discharge people appropriately quickly, and we are unblocking a huge number of operational issues in the process of doing that, and that started then. September, probably the joint equal biggest news story of the year, the CQC awarding us good overall, and massive celebration and from our staff about being recognised for the amazing work that they do. The October people story, well, I think that goes to renal and the opening of their new dialysis unit, but actually providing an environment that's actually fit for purpose for our staff to operate in. That's been a big success story. I won't do the other story in October, that's coming up. November, we ran our long service awards, and literally hundreds of people have worked in Epsom and St Helier for 15, 25, and for the NHS for 40 years. And we had special events to commemorate it. There were so many people, we decided to do it over several nights. We hired Bourne Hall. We gave everyone a great celebration, awards, and they met Gillian and I and many of us during it. And the buzz in the room every night was incredible. Yep. And so many people said the reason they stay working for Epsom and St Helier is because they love the people they work with and they love the communities they serve. And then December's people story is finance. So we have been doing a joint piece of work with our two commissioners in Sutton and Surrey Downs to work together on how can we collectively make ourselves more efficient without and improving quality at the same time and working in a joined up way. And Rakesh and the teams won an award from the Healthcare Finance Managers Association for amazing joint working in the finance space to improve patient care. So not often the finance team get awards. Right. So that was the summary of the year.
Oh, well done.
Right.
And anything else?
And then the third thing is what's sitting on all your chairs in the audience, which came out after we produced had to do the board papers. So on Monday this week, our three commissioners, so Surrey Downs Clinical Commissioning Group, Merton Commissioning Group and Sutton Commissioning Group, met together at Bourne Hall to take a decision on were they going to approve the pre-consultation business case for the £500 million investment in Epsom and St Helier to build a new specialist emergency care hospital on one of the three sites and refurbish Epsom and St Helier. If they were going to approve that, were they going to approve the preferred site for the specialist emergency care hospital, which was Sutton, and they approved both the PCBC and the preferred site for the specialist emergency care hospital being at Sutton. And then it was, would they be prepared to go out to public consultation on all of this, which they said yes to. So the public consultation started on Wednesday. It goes on until the 1st of April. And what you have got on your chairs is the leaflet, which is just being opened. The thing that's blue with a syringe on the front saying injecting £500 million. That is being delivered, we hope, next week by the Royal Mail to every household in the borough of Merton, the borough of Sutton, and all of the geography of Surrey Downs. Plus, we've done a postcode trawl of any postcode area where more than 20 people have used Epsom and St Helier services in the last year are getting the leaflet as well. So it is a massive distribution of the leaflet. And then the other document you've got is a landscape document produced by the CCG's programme team, Improving Healthcare Together, of all of the consultation events and ways in which they are going to consult over the next few weeks, so that you can see that if you haven't already seen it before. There's a website, the Improving Healthcare Together website, which has all of the papers, including the pre-consultation business case on it, all the consultation materials. We're hoping for a very positive engagement with our communities about this, because the hospital is very excited that the commissioners have now launched the public consultation, because this is going to secure the future of Epsom and St Helier for decades and decades to come. And of the investment the government announced in the 6 new hospitals, we've secured the second biggest investment out of all of the 6. So we're very keen to have our new hospital facilities. So I just thought so we haven't made it an agenda item on our trust board because it's not our consultation.
Right.
But there are lots and lots of opportunities for people to come. And the programme would be very keen if lots of community groups wanted the programme and some of us to come to your meetings over the next 3 months. So I know that, for example, some of the MPs are considering organising their own public meetings, which we'd be delighted to help support. And if any residents' associations wanted to do the same, that would be fantastic.
Okay.
Here we go.
And I think our general message is we want as many people as possible to respond to the consultation.
Yeah.
So, thank you, Daniel, for that very thorough review of the year. Were there any comments from other board members? No? So we're asked to note the report. Thank you. That takes us on then to item 4, which is this is quite a meaty item. We've got a lot to get through, and it's core board business, actually. We're going to start with our Patient Safety and Quality Committee chairman, Pat, and you'll take us through your report. Then we'll do the reports of all the other chairs, and then we'll look at the integrated performance and risk report, going through each category carefully. So there's plenty of opportunity for us to cover all the bases. So, Pat.
Thank you. Thank you, Chair. You will see that there is a written report of the key items that were discussed at the meeting that we held on the 6th of December. And I should mention at this point that because it was earlier in the month, we didn't actually have the data that is in the pack for the month of November because it was too early in December. So that has not been discussed. So if there are any points from that which emerge either as you've looked at it already or when Ruth talked about it, we can take that at our next meeting with the next month's report that we will have for December, I think, Ruth, is that right? But back in the beginning of December, we had a busy meeting which we discussed the IPR then, which was for month 7. And the specific things that emerged from that, those discussions around the IPR were that we received the report into a spike in deaths back in the earlier part of last year, which concerned us about elective patients, and those have been looked into. There were 12 where we wouldn't expect to see more than 3 or 4. And indeed, when they were examined, it was established that these were coding or other issues, and that, in fact, the number of elective patients that died was at 4 during the period that we were looking at. So we were very pleased to be assured that there wasn't any area of concern there. Each death was looked at individually, and we noted that in July the level was back to what we would expect to see. We did discuss the stroke figures. These have been fluctuating, and although we know that we've got very good quality of care, there is a concern about the capacity of the 2 units and the way that the variability reflects the differing pressures on the sites, and we do keep that under close scrutiny and will continue to do so. The VTE is another area where we've been challenged for some long time. We're still not achieving the standard that we would like to do, but there has been a reorganisation within the Medicine Directorate, and we're hoping that as a result of that we will see it climbing again. This is a difficult area to get absolutely right, but we do need to do so because the embolisms are causes of deaths from time to time. There is, in this month that you have with you, the data that you've got now, some data on C-sections in maternity that might be a cause for concern, and we will be looking at that at our, we have got a report coming to us in detail, a deep dive in February, when we will hear back from the maternity team about the reasons for that. But we know, and I think Ruth will address this when she talks about the IPR, that there have been changes in policy around the delivery of maternity care which impact on that data. We were very pleased to note that incident reporting is improving the timeliness, and we were assured by the fact that we now have more trained investigators, so that more investigations can be done in real time and lessons learned. We considered the corporate risk register as well, and we made an adjustment to one of the corporate risks, which reflects the fact that because of staffing, difficulties of recruiting staff across the two sites, we do not meet the requirement to provide for 7-day services on both sites throughout weekends. This is something which we've been well aware of for some time. It's virtually impossible with our current staffing model to deliver that. So there is a lot of work going into making sure that priority is given to those who need consultant attendance over weekends, and that those are recorded in patient notes. So you will see that there is a revision to the risk to reflect that. We received the quarterly report on the mortality reporting, which we're learning is highlighted from the reviews that are now being conducted into all deaths, and the lessons are being applied, and the report, which I think is on the agenda, can reflect the lessons that and the ways those lessons are being disseminated throughout the trust. We requested a report on winter pressures, and we were very pleased to note that work had been going on since October. And I'm sure that those are one of the reasons, the fact that the planning has been so good is one of the reasons why, though not at the 95 level, our A&E performance is better than the national average. On CAMS, this is child and adolescent mental health. This is, as you will be aware, been an area where we've had concerns for some time, and we were really pleased to note that there is now proper support at both sites. We're going to keep it on our radar because the money is not perhaps totally secure for this sort of support going forward, but at the moment there has been a lot of effort put into it, and we are not seeing the pressure on the children's ward that there was before, which is extremely gratifying. And then we had a fantastic report on patient experience from the team that goes to extraordinary lengths to try and find out how patients feel and to respond quickly to any complaints that we receive or any concerns that we have. And that's reflected in the feedback that we get from patients, which is, I think, universally improving over the year. Lisa. So we wanted to congratulate the teams that are involved in that work, because it really is something which we take very seriously, and it's good to get the feedback that patients can see the benefit. I think that's all. Thank you, Pat.
Thank you very much indeed, Pat, for the very thorough report back. Any questions or comments from colleagues? Aruna.
Pat, can I ask about the coding issue that you brought up right at the start? What have we done about that? Because that could be quite misleading if people aren't coding things correctly.
We know by individual ward area where the issues are, particularly in haematology and renal, and so we've done work with the teams to make sure they're aware of the importance of making the notes clear, so that what has happened here is a patient is admitted for an elective episode of care, which is undertaken without complication, but they have complex coexisting health conditions which then deteriorate, and they then convert from being an elective patient to an emergency or an acute admission. So the teams are now much more cited on the importance of being clear when the type of admission changes, and early indications are that the coding in the last month has been much more accurate. So targeted work with the teams involved.
Thank you, Ruth. Any other points people wanted to raise on this report? No? Okay, so we're asked to note the report if people are agreeable. Thank you. So that takes us to Finance and Performance Committee, and in Richard's absence, Elizabeth, you've kindly agreed to report back.
Thank you very much, Gillian. First of all, I note that the report title says that this is about the August, September and October meetings. It's not, we're talking about the November and December meetings. So just to clear that up before we start. The Finance and Performance Committee, we started off by looking in both meetings at the performance side, and you will see that at the November meeting, there were concerns that the cancer target had dipped slightly. But when you read through to the December meeting, you can see that it has picked up again and that we did follow through on that piece of information. Obviously, we have been monitoring very closely the A&E target. And looking back at my notes that I made during the meeting, I see that I've got a note which said that GPs are redirecting about 30% of the outpatient attendance at St Helier. So the people who are coming to us are the very sickest and the most acute people. And when you put our performance that Daniel's already mentioned in context, it does show that we are doing the best we can for the people who come to us at that point. Moving on to finance, we are at the point of the year where we're beginning to consider where we're going to end. At the moment, we are saying that we are on target. We are very, very slightly ahead of target at both the October and the November finance reports by just under £1 million. £1 million is a very, very small margin at this time of year. We are still expecting to end the year on plan, but we have to accept that there is risk in that expectation because of the winter pressures. That's correct, isn't it, Rakesh? You will also see that we have spent a considerable amount of our time discussing the Trust's capital programme, all of the things that Daniel has mentioned during the course of his update. At the moment, it is on track. We have spent something of the order of £19 million already, and we are expecting by the end of March to have spent over £40 million during the course of this financial year. It is definitely a case of keeping our foot firmly on the pedal and moving forward, because we have got an enormous number of projects on the go. You will also see that at the December meeting, we did discuss 4 very important business cases. Finance Committee spends a lot of time at scrutinising ideas, and they frequently come to Finance Committee several times before they are signed off, because there are risks in them that we wish to know more about the mitigation before we are prepared to recommend them to the board. And these 4 business cases, which are the PACS collaboration, the Microsoft licensing our security services, and the renal satellite dialysis unit, have been through that process, and we are able to give assurance to the board on them, Gillian. Thank you.
That's excellent. Thank you very much indeed, Elizabeth. Any questions or comments on what we've heard from Elizabeth? No? Okay, so we're asked to note that report. Thank you. Takes us on to People and Organisation Development. Aruna.
Thank you, Chair. So I think our last meeting was actually quite a positive meeting. Lots of progress made on the people and organisational development front, but of course still lots of work to do. So on the very positive side, we have now got a new guardian of safe working, Dr. Andrew Crombie. We have, since we had the meeting, also found our deputy HR director, which is really very positive. And a lot of very positive presentations, really, on the back of the hard work that people are doing. So health and well-being right at the top of the agenda in terms of the progress that we're making in providing both mental and physical help, support, physiotherapy and counselling services at our trust. it's always never enough, but we are very aware of that, and we will keep promoting that and progressing on that. Lots of positive progress again on the pod governance structures. We're making progress there. The respect update, I'll pass over to Debbie in a minute, and Lisa to give us updates on that, up-to-date updates. Integrated performance report, I think we are making really great progress in terms of recruitment, but our retention issues still dominate, and we need to do a lot of work on that, and we need to focus on that. So the next meeting, I think there will be a specific presentation of what we're doing really in terms of understanding why people are leaving and what we can do to keep them. And I guess the only other things to add really since we had this meeting is we have closed our staff survey, and we had the best response rate we've ever had. So we're looking forward to what that brings to the table and what information that gives us, but at least we know that we've got a good cohort of people that have responded to it. So I'm going to hand over to Debbie in terms of respect and the civility video. Thanks.
The only thing I wanted to add to what Aruna's just said is around the Incivility at Work video, which was created by our simulation team. Since our last meeting, that video has achieved regional-wide recognition, and both by employers as well as trade union organisations. And what we have done is agreed for other organisations to use that as a training tool, which is really, really positive.
Very much indeed. Were there any other comments on Aruna's report? So I've seen two hands, Elizabeth and then James.
Aruna, and Debbie, I'm absolutely thrilled that you've recruited your deputy director, because you were finding it, you were definitely understaffed. So well done. When does the new person start working with you?
2nd of Feb.
Great. Look, we really look forward to meeting them. Thanks, Debbie.
May I add, I think this is a great example of joint working again with George's, because they helped us find the person. So that's a great advantage.
It's always good to hear. James?
Just to point out, there's a minor typo on the name of the Guardian of Safe Working Practice. Okay. It's Dr. Andrew Combia. And this is a crucial role, yes. As you know, Aruna. And I'm really pleased to see now that he's becoming embedded within the different teams and sending some feedback to Ruth and myself. So we really value that role, because it's another source to triangulate where there may be issues with doctors in training.
And he'll come and talk to us at some point, I hope?
Absolutely, yes.
Excellent.
And we've also got a new chief registrar, haven't we? I should have said that. Rachel Emery. Yes. So we're now fully staffed on that front, which is wonderful.
That's very good to hear. Thank you for that. Martin?
Yes, just a question which is probably covers a few different executive areas, but there's been a lot of stuff in the media about shortage of nurses in the UK, and a lot of stuff about trusts sending teams of people around the world to recruit large numbers of nurses. I just wondered what the view was on that.
Yeah, so thank you. We have considered it, and in fact, at the end of last year, we did a short period of exploring how we could do overseas recruitment without actually physically leaving the country. We did a number of Skype interviews, 50 Skype interviews, and out of that, we've had 10 nurses start. So I think it's a small start, but I think we really wanted to explore the option of not having to leave the country at all to do it, and we've done that successfully. And we had, as I said, we had 10 new starters. We had 5 of them in accommodation, which was, their first Christmas ever outside of their country. So we had to support them very differently. So we are looking at that actively. I think the hesitation has been of the prohibitive cost of going internationally to do recruitment. I was talking to another chief nurse yesterday from our region, and their trust had done it with mixed success, but she found out that they did it by reducing the number of staff that they have working on the wards, and we're not prepared to do that. So they took out one nurse from every roster and used that money to go abroad to recruit, and the results are not what you would hope for. So we will continue to look at that.
Daniel, do you want to come in?
So there's a NHS people plan, a national people plan, and it recognises that in order for the NHS to meet the workforce supply, we're going to have to recruit internationally on a very big scale. So they are now not encouraging trusts to do it themselves, and there will be a national, international recruitment campaign being led by the trusts that have worked out how to do this really well. So like that meeting we were at where you were presenting with the Chief Exec of Yeovil. So I imagine Yeovil Trust will be asked to recruit internationally for a large number of other organisations, and a few other trusts will do that on behalf of others, so that we get a sensible supply of international recruits that doesn't destabilise any other country in the process of doing it. But it'll be nationally organised going forward.
And there is a London-wide plan that's being pulled together, and we're included in that. So we're looking at that from a London perspective.
Well, it makes a whole lot of sense, doesn't it? So that's good to hear. Thank you. Thank you for the question, Martin. Any other points on this report, or can we note it and move on? Thank you. That takes us to, Martin, your own committee, Quality, Diversity and Inclusion.
Yeah. So the there's continues to be quite a lot of positive feedback on this and recognition about what we've done on this. And we've had a couple of visits from people who are influential positions around it. And we do get a lot of inquiries from other trusts. But I'm very conscious that we've made an improvement against really quite a low starting point. And in order, like any change, to keep the momentum going, the next phase of this is really critical. So specifically in terms of the last meeting, one of the big changes was that we spend much more time now hearing from the chair of the different staff interest groups. So these groups are typically around the protected characteristics like BAME or LGBTQ, although actually any group of staff can set up a network on whatever they want to set up. But what it does do is to make people who might otherwise find that they weren't as included as they wanted to be, it helps them to share common interests. It's also a very good place for us to be able to find out exactly what people are feeling. One of the comments from the LGBTQ one, for instance, was that their feeling was that the relatively small number of people who had joined it perhaps reflected the fact that even though we keep saying about our inclusion, that they didn't necessarily feel comfortable about declaring that they were LGBTQ. In other words, they felt that there were far more people. And that's one of the things that clearly we need to work on. And probably takes us to the other point that we also spent quite a lot of time talking about what we were going to celebrate. Because the danger in this area is that you can end up focusing on compliance and on relatively negative issues, whereas fundamentally the point is that we believe the organisation performs better the more diverse and inclusive it is, and therefore the more that you celebrate differences in religion and ethnicity and so on, the better it is. So we had quite a lot of discussion around which events we would focus on. And the last bit is just to remember as well that this does also concern patients too. It isn't only about staff. One of the issues in this area with patients is translation services. And I always try and sort of put myself in think about in terms of the position of the patient. And a lot of what happens is, of course, that you might be on holiday in France and you may have a basic level of French, But if you have something traumatic happen and very stressful, well, you probably are not at the best position to use that French, and you may not have the vocabulary to describe everything. So a very simple technology and improvement in service is now that basically what happens is if we have somebody in that situation, we use a mobile phone. The mobile phone connects up to a 24-hour, 7 days a week service, covering huge range of languages. And the clinician is then able to talk to the translator and interpreter and then come back through that. And we've seen significant improvements in that area. So that's my summary.
Thank you, Martin. I think that point you make about language is so important. As somebody who speaks basic French and certainly couldn't cope in some traumatic incident. So are there any... Lisa, I'm so sorry.
No, Chair, I'd just like to amplify that point, because that's something we've put now into community services. So community services are now taking active part in that. And funnily enough, the language profile has changed as a result of that. So you mentioned French. Actually, French is quite one of our top languages now in the community. So because we now have this telephone survey, it's early days, but the feedback from staff has been very positive. Hopefully that will be reflected with the patients too.
That's really good to hear, thank you. Any other points that people wanted to raise on Martin's report? No? So could we note that report, please? Thank you. Takes us on to Sutton Health and Care. Chris.
Thank you. If that's okay, I'll sort of do Sutton Health and Care and Surrey Downs Health and Care together.
I'm delighted about that, yes.
With subsections. The reason for doing that is that if you've read the papers, there's a lot of commonality about it, which is hardly a surprise, because actually both organisations are looking to achieve the same set of outcomes, which is excuse me, integrated care across their areas. And they have the same benefits and the same issues. The issues which are of concern at the present time are issues like, within the trust itself, but is around staffing. So those staffing is improving, and there are plans to improve the staffing, particularly on the nursing side. It's not where it would ideally be, but this, of course, is a national problem. It's not just a local problem, but we are working our way at it. One of the problems with integration is you then decide you want your IT systems to be integrated, which, of course, they have to be. And that is, as always, a challenge, but we're working very hard on that, led by Peter. And I'm sure we will get there in the end. But it's anybody who tells you that you can join up IT systems and we'll have it done next month, I think I would have some disbelief of that myself. The other thing not actually in the reports, which we should have added, is that we're doing a lot. There is a CQC visit expected on community services later this year. We don't have any date for it, but we are both areas are working to develop their plans for dealing with the CQC visit. I think encouraging for me was the Sutton board earlier this week. There was a report that the staff feel fairly confident. They've done CQC. They feel fairly confident about having to do it again. And if your staff feel reasonably confident about it, that's quite a good starting place. There's obviously a lot more for us to have to do as well as an organisation. Splitting the two areas, Sutton, as you will see, the primary care network clinical directors are now fully integrated into our integrated alliance. Funding has been agreed for the rollout of end-of-life care hub, which is a central point for patients and carers to contact professional help for people who have issues with end-of-life care. It's the beginning of a broader end-of-life care strategy in Sutton, which will involve all partners within the alliance. Within Surrey Downs, one of the problems of being very good at something or very successful at something is one gets visited. So we're very pleased that Baroness Dido, who's chair of NHS Improvement, decided she wanted to come and hear the good news of the integrated work and treatment that goes on here at Epsom through the Surrey Downs Health and Care Initiative. I think I just was reflecting on this. Obviously, both of these care alliances are alliances of different partners, which I mentioned previously. But there is a benefit on having one organisation that sort of arches across both of them, because that way you can try and make sure that the learning in one is transposed into the learning in the other, which is always a good idea. That's all I have to say, Chair, unless Thurza wants to add anything.
Well, there may be other questions or comments. Thurza? No? Anybody else? Elizabeth?
Chris, could you just tell us a little bit about the staffing and people challenges that are highlighted in the report?
I think I would pass the buck on the details of that one to Thurza, if that's okay.
And I might well be passing it to Arlene as well, so we better watch out.
No, I'm not sure we want all this passing the parcel.
So if I can just say that we inherited large vacancy rates, particularly around nursing and particularly around Band 5, which is the lowest level of nursing. Compounded to that, particularly in the Sutton area, we've had a higher than we would have anticipated and liked attrition rates. So we've had more people leaving than we had starting. A large part of the focus, therefore, in terms of what we're looking at moving forward, has been both how do we recruit. So there's been a very successful recruitment campaign for Sutton across all of our partners, so not just for the health part, but for all of our partners. But the focus of the work that's going on now is how do we make people want to stay within Sutton and Surrey Downs Health and Care. And that's a large part about how people feel an identity of the partnership, that they feel that the work that they're doing is valued, and how they feel the tools that they need to do the job, which is particularly around the IT system and support around education and training, is in place.
Thank you very much, Thurza. Was there anything you needed to add, Arlene?
As part of the programme of looking at this, we're looking at rotation through community, so encouraging staff to rotate so that they don't just work in community but across, so we can get a seamless pathway for patients as well.
And there's a lot of evidence that it really helps staff retention, because staff are getting really good development by moving through the different areas. I wanted to ask a question, if I may, from the Chair. I know chairs aren't meant to do this, but I don't think we can really pass by the comment in relation to Surrey Downs on the risks about partnership governance and identity and the challenges due to the employment arrangements. Are we making progress in relation to this? Is this a Daniel question or a Thurza question, or a both? No, if it's you, Thurza.
Well, as you know, you and I met with the Chair and Chief Executive of Central Surrey Health, who is the major employer of the staff in Surrey Downs. And we articulated that we needed a closer relationship to make it more easy for staff to have the right identity with Surrey Downs Health and Care. We haven't made much progress in actually delivering on that. So I don't think the issue is resolved at all. And interestingly, we had a South Region Assurance meeting of Surrey as a place. And that issue came up from a number of the organisations in Surrey, that there are so many organisations that it's quite challenging. So that was heard by the Regional Director for the South as an issue.
Okay. So it's clearly ongoing, and I think you and I probably need to pick up with the Chair and Chief Executive that discussion that we had. And Chris, in terms of assurance, I know that these committees are a bit different to some of the other board committees. Do you think the level of assurance of the committee, of the overall quality of the work is generally satisfactory? Do you feel reasonably assured about things?
I think the answer is simple answer is yes, in the sense that I think we get the right information, and it is that we get the details and the plans. I suppose looking back at some previous roles I've had, I've seen some of this data which maybe are new, not new to a secondary care trust. I've seen in other places. And we're getting similar levels of data and information coming through. So I do feel, acknowledging that there are... acknowledging that there are issues such as the IT and staffing and so on, I do feel we get the right information and people are making plans as best as possible to deal with the issues that arise. Yes.
On assurance, we do get quality data coming to PSQ, and among that, there has been some concerns about pressure ulcers, that being the most reported harm that there is in the community field, and we are having a deep dive report on that coming to PSQ, so I think there is some other coverage of the assurance issues other than the partnership boards.
Okay, that's good. Thank you for that. Any other points on this? Otherwise, could we note both the reports, please, from Chris and his committees? Thank you. So now we're going to look at the integrated performance report, and I'm going to call on the relevant executive in appropriate order, and they will add, if necessary, to issues that might be more current or weren't able to be covered in the updates from committees. So I'm going to start, Ruth, with you.
Thank you. So I was going to highlight two issues, one of which Pat alluded to, that weren't discussed in detail at the PSQ, that pertain to the quality sections of the IPR. Both sit actually on the maternity dashboard.
Yes.
And we have two red indicators on that dashboard, which I think it would be negligent not to discuss and articulate what we're doing in relation to those. One relates to the caesarean section rate, and one relates to the birth centre usage rate. In terms of the caesarean section rate, as is described here, there has been a steady and sustained increase in our caesarean section rate really since April of last year. And having had detailed conversations with the maternity team and looking at their analysis, we believe that that rate is linked to a number of changes, if you like, in clinical practice and guidelines that have been recommended to reduce the rate of stillbirth and early neonatal death nationally. We're ensuring that all caesarean sections undertaken are reviewed by a consultant afterwards to ensure they were appropriate, and we have assurance that that actually is the case. And we are working with the maternity team, and they are working in turn with colleagues both regionally and nationally to actually see whether the benchmark that we currently have in terms of a target needs to be redefined for the 2021 IPR report. But in terms of the quality of care given to women and the appropriateness of sections, I think we have assurance, and we have asked the maternity team to come and present to the next PSQ on a number of different indicators. The other one actually links estates and quality, and it relates to birth centre. It's not immediately evident from this, but the fall in use of the birth centre really relates to the Epsom site. The birth centre there has not been able to be used for quite a bit of sort of late autumn, early winter, because a key lift has been out of action. And for safety reasons, when one of the lifts is not working, you cannot safely use the birth centre. So I just really wanted to flag that up as a link between estates and quality. It is now restored and functioning, but it remains an ongoing risk.
Thank you, Ruth. Any questions to Ruth on either of those? No? So, Arlene, you've got a number of areas. Is there anything that you needed to flag up for us from your pages?
So the only thing really would be under the safety thermometer, and we've mentioned it briefly, that pressure ulcers continues to be the highest reported harm incidence we have both in the acute and in community. And we're doing a deep dive into that and looking at what we are developing a plan to improve that. It is, you know, in terms of community, it is the highest reported incident in community. That's a national thing. That's not just local to us, but in hospitals we need to do something about it. And we have just agreed that we will have one tissue viability team across the acute and community led by the nurse consultant, so that we can join forces to address this issue. The only other thing I would like to highlight is that we still have no MRSA bacteremias, not everything, and we are just one over for C. diff, the trajectory that we've been set, which is quite good for us.
Well, It's good, particularly because this year's target is so much more challenging.
It
isn't
is, absolutely.
So, and you know, any extra case of C. diff isn't something we want to see, but we knew that this year was going to be very challenging because the national targets format had changed. Any questions or comments for Arlene? No, thank you. Lisa, anything from your pages?
I'd just like to highlight one thing, if I may, Chairman. On the Friends and Family test for A&E, we have struggled to get previous years the numbers of response rates and also the response in terms of people saying whether they would recommend the organisation as a place for care has been low. We are consistently now hitting really high levels, both in terms of the response rate and people saying they're having a good experience in A&E, despite the fact of all the challenges that they are facing. So I think this is a real recommendation to the teams and highlight the teams that they're doing an amazing job, because we get thousands upon thousands of patients who respond to this every month. So it's a really good indicator that everybody's trying their really best for the patients.
Thank you, Lisa. Any questions of Lisa for her pages? No? So, Sue?
Just a couple of things from me. As Elizabeth mentioned earlier, our cancer performance is back on track in November, so October was a blip. Elective care performance is still very challenging. I just want to assure the board that the 6 patients who waited 52 weeks have 5 of them have been treated and 1 has elected to be treated later this month. He chose to delay further. So those are all now sorted. We're very challenged with our diagnostic wait times. And we've got a recovery plan being drafted at the moment. Main areas of concern are MRI and ultrasound. Those are our 2 biggest areas of concern. But we do have a plan, and we've been working with Rakesh on that, and we've met with the clinical services team. Our cancelled operations, we're getting people back in within 28 days, and those numbers are slowly coming down. And the good news is our elective inpatient length of stay is actually down. For critical care, despite being very challenged with our sick patients over this winter, we are always managing to keep 1 bed empty on the St Helier site so that we can admit very quickly where we need to. So I think just assurance that despite being busy, and even though it might take longer than 4 hours to get somebody out of critical care to release a bed, there is always a bed available. So that's just a quick update there. And on urgent care, as Daniel said, this is a national issue. We're not taking our foot off the pedal. We are consistently trying to reduce the number of patients who are waiting more than 4 hours. Some of the key drivers are how we manage flow through the hospital. So we've got a big piece of work on reviewing our flow through the emergency department starting next week. Our All Systems Go that you mentioned earlier on today as well is happening over the weekend this week. So we're trying out, can we keep up the pace over the weekend and hit next week in a better position than we normally do. So we'll be working hard over that this weekend. Our ambulance arrivals are very challenging, and having 7 to 9 ambulances turning up in 1 hour makes it very difficult for the teams to respond. But again, we're working with the system to try and improve on that. And the GP system that Elizabeth mentioned earlier is a GP sitting in A&E at St Helier at the moment who redirects patients, and we're seeing very positive results from that, people coming in and being redirected out to a GP appointment. We've seen up to 60% of patients from Sutton who've seen that GP being redirected out. So there's lots of work going on in ED, but it is very, very pressurised at the moment.
Thank you, Sue. That's a really good summary. Any questions? James?
I just want to pick up a couple of comments about critical care, because it is so important when the hospital is so busy and stressed that the critical care environment feels safe. When patients get admitted to critical care, the mortality rates are still very good. And there's as Sue mentioned, there's a huge amount of work to ensure that we work really hard to keep 1 free critical care bed open. And just to provide assurance to the board that our clinical director for critical care is actively monitoring every referral and the time delays that patients have getting onto critical care once they've been referred, and we're monitoring any potential harm. And so far we're feeling reassured about the processes, even though of course we'd like more capacity.
Thank you, James. That's very helpful. Other questions or comments? I've got one, Sue, if you don't mind. You referred to the action plan to bring diagnostic waiting times back to where we need them to be. What date do you think we will be back to where we need to be?
So we were hoping to have a paper for discussion next week at our internal exec meeting. Unfortunately, we've had some sickness within the team, so I just need to check where we are with that after we finish today, but within the next week.
So next week's the action plan, and until you've seen the action plan, it's impossible to know whether we're
it is
talking about 2 months or 3 months or 6 months.
It is about resource and about trying to find staff to man the additional hours that we need to run the extra MRI scanner that we've got. Yeah. So it will within.
So can I just...
Don't, sorry, Daniel. You're finishing off and then Daniel will come in. Yeah.
No, I think that's where we are. So it'll be this week that we should have a report, and we should have an action plan within the next month.
Thank you.
So in terms of increased capacity, so we should, in the next couple of weeks, have an additional MRI scanner open at St Helier. And then we're pretty confident we're going to hear that we've been given some extra capital from the government to have an additional CT scanner here and an additional endoscopy room at St Helier, both of which would need to be operational by the end of March.
Okay.
We're just waiting the final confirmation that that's going to happen. We've got it in email, and now we need a letter. But we're all ready to press go on both those things, should it happen.
Okay, so that's very encouraging. Thank you for that. No other points? Yeah. I'm so sorry, Pat.
So can I just clarify that it's the equipment that we're short, because you mentioned staffing. So if we get the new equipment, will we be able to staff it?
Well, that is exactly what we're looking at the moment. So I think we've got a plan which shows that with the additional equipment we can bridge the gap. We've got a backlog of patients that we need to manage through working some additional hours, and that's where we need some additional staffing. But we will reach a point probably by April where we'll plateau and we'll have enough capacity to manage with the staffing in core hours. But we're going to have to ramp up a little bit before then.
Okay. So will Finance and Performance Committee keep an eye on this? Yes. Yeah, thank you, Elizabeth. Right, so Debbie.
I just want to add a couple of things. We've talked about recruitment earlier on, and whilst we've been making really good progress with our recruitment numbers, we need to keep up the work with this. And over moving into 2021, we are now supporting the divisions to develop their recruitment plans to enable them to carry on that work and in a planned way. So that's, I'm hoping, will help us move forward and build on that. In terms of retention, we talked about the resources in HR, and with the new resources, we'll be able to have a focused piece of work around that. And I just want to highlight from in the IPR around our training and our appraisal records. You know, this is an area that we definitely need to work on, and we're focusing our resources in Q4, the final months of Q4, to just get us up to scratch with that. And it's an area that we did achieve last financial year, so we just want to make sure we meet our targets around that for this year. There's been particular issues around the systems we use and the interoperability, particularly with the community staff, and we want to make sure we have alternatives in place to ensure that we can capture data with them.
Thank you, Debbie. Any questions to Debbie? So I've got a couple of hands. So Elizabeth and then Martin.
Debbie, I'm not sure whether this is a question for you or for Daniel, but one of the things that we normally talk about at this time of the year is the percentage of our staff who've had the flu vaccination. And I wondered where we were on that metric.
7.
Who is it for then?
I don't know, but I know the answer.
This is a unitary board, yeah?
Do you know the answer?
Yes.
Oh,
Yes.
We're at 77% at the moment, although we need to validate the data, which we'll be doing over the next couple of weeks when our lead, occupational health lead, returns from leave.
So the thing that's really important about it is the community staff generally have not had very high flu vaccination rates, and we have managed to get the community staff vaccination rate pretty much up to the same level as the hospital staff vaccination rate, which has taken an extraordinary amount of effort and encouragement, but I think that's a very good thing. So we were required to get to 80%, so we're very close. And if we hadn't had the community, we would have done it. But getting to 77
having the community brings many other benefits.
Exactly.
So next year we need to make sure that we beat the national target. I might start having a competition between the two hospitals on this.
St George's always wins this one.
George's normally does a good job on that one. Yeah. So thank you.
Yes, I just wanted to ask about the retention issue. Do we know anything about how we compare with others? In other words, it could be, I guess, that it's a national issue and it's people leaving the NHS, or it could be that it's people leaving us to go to other parts of the NHS. Do we know?
Yes, as a local acute provider collaborative, we do share our data and benchmark against each other. It is a national problem, and there are national actions, including actions in the new interim people plan around how we address it. So as an APC, acute provider collaborative, we are trying to work together to ensure, the chairman mentioned about career pathways, to ensure that actually not only as a local organisation we can support people to have enhanced career pathways, but also as organisations to move around and experience different things, so that we can, that's an example of the work that we're trying to do to improve retention. But we're working collaboratively around that.
Allowed.
So I would say we are good at attracting people into Epsom and St Helier, and a lot of people stay for a very long time. But the consequence of a lot of people staying for a very long time means that lots of people who are very hungry and ambitious to develop themselves often find that they currently have to go somewhere else to develop themselves. So our retention strategy is actually all about how do you retain all the bright, young, enthusiastic people who we recruit and give them all the career opportunities within Epsom and St Helier, so that they then can also become the people who stay a long time. So it is. I think it's quite clear where we need to focus the effort on in retention.
And there is work going on, isn't there? I think it would be helpful if Pod could look at some comparative information on that as well. Yeah. Okay.
Can I just add?
Yes, I'm going to start having to hurry people along. So there's not been enough time allocated on the agenda for this item, but we had 15 minutes spare, which we've used up. So Arlene, please do come in. But I've still got Rakesh and Peter to call in this item, so we're a little bit behind.
Thank you. I just wanted to add on the retention fund that we cannot underestimate the impact of the culture. And I think the big culture of a piece of work that we did last year is going to help in the retention work that we're trying to do, but it has affected retention so far.
So if there's no more points on that, Rakesh, was there anything you needed to add?
Nothing to add. The report shows that we're on slightly ahead of target, Elizabeth said, but just wanted to flag up at this early stage with the board that we're seeing financial pressures come through in December to do with winter. Yeah. So additional staffing for additional beds and medical staffing, and I think that will, when we do the detailed analysis on our year-end forecast, may put pressure on the year-end forecast on that.
I think wise to make that comment. Thank you, Rakesh. So nothing to ask, Rakesh. So that moves us on to the corporate risk register, Peter.
Thank you, Chair. The corporate risk register really reflects the conversations that we've just partially had at the board's table and substantively in the board subcommittee. So the elements around staffing issues or performance, money and variability of care have been covered off, so there's nothing really necessary to add in terms of the specifics, because the work has been done in the subcommittees to get here. So really this is an opportunity if others from the board have seen something or feels not reflecting, or they want some clarification on components.
Yeah, thank you for that, Peter. So anybody got anything they want to raise? So I have, which I'm sure is down to my ignorance rather than anything else, and it's 212 about delays in completion of investigations of incidents within medicine. I see it's on a 20, which is jolly high, isn't it? And I just think, I realised when I was reading it, I don't think I'd registered that well enough. Could you say a little bit, Ruth?
So the medicine team, and that's the sort of medicine director stroke division, have been challenged in completing incidents in a timely way because of the volume they have related to other clinical areas. It is still a 20 because the delays in completion potentially lead to delays in learning, reflection and changing practice, and that's why it's intentionally being captured at that level. However, there's a huge amount of work being undertaken, which I think means that there'll imminently be able to be a reduction in that score. And that relates to, firstly, there's the divisional restructure. There's also a restructure of the quality team and the quality team resource and allocation. And then there's also a change in our incident reporting processes and panel. And all of those three, I think, are already starting to lead to a modest improvement, which means a reduction in the score, I think, will be achievable by the next time we present this.
Okay, that's really helpful. Thank you very much indeed, Ruth. Any other? Oh, sorry, Chris.
Thank you. Sort of similar question, but about 2.4a around adequate care for CAMS patients. I know quite a lot of work's been done to try and improve that, so I suppose I wondered why it was still so high.
Arlene and I can take this together. It's still high. The position has improved. Particularly the challenges have been on the Epsom site. And since the beginning of November, we've had a practitioner working in ED with CAMS training who can see the 16 and 17-year-olds and much closer working with the CAMS team. So I think, as was articulated in the PSQ report, we're seeing some reduction in the pressures, but we were very cognizant that when the ward gets busy over autumn and winter with medical patients, the pressures then in looking after the CAMS patients will increase. It's been easier to manage over the summer when the ward has been quiet, and for that reason it remains 16. But Arlene and myself are in close liaison with the teams, and again I think we anticipate a sort of reduction in this over the coming months.
Thank you. Thank you. Okay, was there anything you needed to add, Arlene? No?
No.
Lovely, thank you. Okay, so that brings us to the end of item 4.1, which is obviously a very substantial item. We've used 45 minutes, so I think in terms of agenda planning, we need to extend that. If our patient had arrived, hadn't had the difficulties she did, we would have been struggling there. But that felt, well, we'll reflect later on about whether we've got that right, but it felt like a discussion that needed to be had, and I did feel I was still moving people on at times. So 4.2, quarter 2 update on the quality report. Ruth?
Just be locked up my electronic system,
yeah,
but hopefully I have rehearsed this adequately, so thank you. So I think just to remind the board that for this year, 1920, it's the first year that we've actually, as a trust, made a commitment to producing a quality report as opposed to a quality account. To remind you of the differences, in a quality report, which is mandated for foundation trusts but not for all trusts, you monitor progress against key priorities that have been agreed with stakeholders, and in addition report on a number of metrics, in this case 16, which are both nationally mandated metrics and local metrics. What the report here does is highlight the progress in quarter 2 against the priorities which were agreed in sort of February of 2019. It's interesting that actually a lot of this has been discussed as we've gone through the board meeting to date. The first priority we agreed was that we would increase the proportion of patients seen daily by a consultant. You will hear that that is proving challenging because of the resource available. I think the teams are making progress, and our priority at the moment through quarter 3 and quarter 4 is to make sure that we're prioritising the resource we've got in terms of consultant provision at weekends to make sure the right patients are being reviewed. So there is progress on that indicator, but we will, just in terms of risks, we will not achieve completion of that indicator as we progress into quarter 3 and quarter 4.
I think we knew that from last month's board, board, didn't we?
In terms of learning from avoidable deaths in hospital, we have the mortality report on the agenda. I think there's been a very positive story there with very good uptake of structured judgment reviews and enhancement of learning, and I think no concerns to highlight in terms of that. In terms of sepsis management, good progress through Q2. We appointed clinical medical sepsis leads, and subsequently a lead sepsis nurse has been appointed. And work continues in conjunction with the Simulation Centre to improve sepsis care with regular reporting to radar. And this does not at the moment present any particular risks as we migrate into Q3 and 4. In terms of priority 4, it was around really working as an integrated care system to prevent avoidable admissions and support patients remaining at home. And I think, again, we've heard through the Surrey Downs and Sutton Health and Care reports how that's being achieved. And then the priority 5 related to our focus on carers, which Lisa's team have been really leading on. And I think that the priorities and the progress report here show good steady progress through Q2, which I know has been maintained through Q3 in relation to that. We will be meeting with stakeholders at the beginning of February to agree the new priorities for 2021 and to determine whether any of these priorities for 1920 are now sufficiently embedded and can come off the list, or whether they should be maintained through the next year. The remainder of the report looks at a number of national and local KPIs or indicators which are deemed to be good markers of quality for an organisation. I'm actually not proposing to go through these in detail because they're already, you'll see all of these actually are on the Trust IPR. So what this report does really is bring together different strands into a single unitary report, but I don't think there's anything in terms of the indicators I need to highlight. Happy to take questions.
Excellent. Thank you, Ruth. Any questions to Ruth? No? Since we've been sharing this, I need to get back to my own notes. I think we're just required to note the report. So can we do that? Thank you. That takes us to item 4.3, the Never Event report. Ruth, you're on again.
Okay. So in terms of the Never Event report, you will be aware that whenever there is a Never Event in any NHS organisation, there is quite appropriately a requirement that that Never Event is, once investigated, presented and discussed at public board. Clearly there is a balance to be achieved where the identification of the patients is protected, so that you will understand that I have to be cautious in terms of how this is presented. What this report does is it summarises 2 incidents that happened in the summer of 2019.
Which we're familiar with, actually.
Which you're familiar with because they've been discussed in detail through our Patient Safety and Quality Committee. And just to summarise, I think, and focus really on the key learning. In the first case, a pain block was inserted into the wrong site in a very complex patient who was about to undergo surgery. The patient did not suffer any harm as a consequence, underwent the surgery uneventfully, but clearly a robust investigation was undertaken, and there was a large amount of learning as a consequence of that. I think key things that came through from the learning was this was a very complex patient with lots of healthcare professionals involved, and in the anaesthetic room, in prioritising his clinical care and condition, with lots of clinicians involved, there was a lack of clarity about who was leading and coordinating the care. And I think that's a key learning when you've got lots of clinicians involved. And so the teams have taken that away and are now much clearer in these complex situations about clarifying who the lead clinician is and who is coordinating the checking processes that take place in the pre-operative room. The other thing that came through is that, again, appropriate time was not taken to complete key checklists. And so a recommendation from this was the institution of a new, if you like, pause moment called Stop Before You Block, which means before you actually insert a pain block, time is taken to stand back and ensure that sighting is appropriate. And so the Stop Before You Block kind of posters and way of thinking have now been launched as a consequence of this case. And I think the learning, as is always the case, the learning from this case has potential to be shared much more widely across the organisation. And so this has been shared at our trust-wide panel so that learning can be taken across all teams. In terms of the second case, the scenario here was that a patient there was who was scheduled to have an outpatient appointment and not a procedure, actually had an outpatient appointment and a procedure undertaken, the procedure having been intended for another patient who was waiting in the same waiting room. Now, there has been a very detailed investigation in relation to this, which highlights a number of issues and particularly highlights the importance of the patient identification policy being carried out. Our patients are identified when you check in to outpatients, and that clearly happened. We actually have other checking processes when patients are called to be seen and also before a procedure is undertaken. But despite having 3 checkpoints, the procedure was undertaken inappropriately on this patient who did not suffer any harm as a consequence, but it raises really quite fundamental questions about how our patients are identified in an outpatient setting. Our teams are currently reviewing our patient identification policy. All clinicians have been reminded of the importance of patient identification, and I think the key learning is that if you've got a patient called Joe Bloggs, that you don't say to the patient, you are Joe Bloggs, please come with me. You actually say to the patient, please can you confirm your name, your date of birth and your address. And you don't therefore confirm your own bias as to who the patient is. So that's been sent round as an immediate action for all staff. But I should add that the Health Safety Investigation Branch, who are a national body who look at where there is potential for incidents in one organisation to have national learning, are working with us on this case, and there'll be further learning which we'll bring back in due course.
Lovely, thank you very much indeed, Ruth. Any points people want to raise? No? Was that a no? Is there some?
No, there was needs a
Oh, it's something straightforward like hydration. No, that's quite all right. We're asked to note the report, and that takes us on to 4.4, the mortality reporting and mortality peer review, quarter 2.
Thank you.
Back on.
So this is our quarter 2 mortality report, which you'll have heard was discussed in quite some detail at the Patient Safety and Quality Committee. I'll start by reminding the board that the report, which is produced on a quarterly basis, firstly describes how we undertake mortality reviews in this organisation. And actually, we have worked jointly with St George's on this and have started with the same approach George's do, which is an approach where we have 2 levels of mortality review that are undertaken. Level 1 review where there is no concern, and what we call an SJR or a level 2 review if there are concerns expressed from any source. What I would like to highlight in terms of key points is that there has been a very significant step change in year in terms of how we undertake mortality reviews, and that relates to the appointment of 6 mortality reviewers who started work in May. And what we have found now, and you'll see here, is that we are actually doing an awful lot more what we call structured judgment reviews or level 2 reviews, more in-depth reviews, because we now have the appropriately trained resource to do that. And as a consequence, are doing less of the level 1 reviews. We think that's a very positive step, and between the 2 processes, we are now reviewing about 70% of all deaths that occur in the trust, and most importantly, getting a lot of learning from that, which I'll come on to. The report presents here the Mortality Dashboard, which goes to our Patient Safety and Quality Committee, goes to our Reducing Avoidable Death and Harm Committee, that's RADAR, on a monthly basis. And I think the key things I'd want to highlight there relate to the fact that we've got good coverage and undertaking of the reviews. And also specifically, there were 2 deaths in the period of patients with a learning disability, and the reviews were undertaken in a timely way, which is a very important thing to note. A lot of the learning we get from these reviews is positive. And I think before I go on to what could be done differently, it's important to highlight aspects of good care, which consistently include good end-of-life care with good MDT working. Very pleased to see consistently good feedback on the care in the acute medical units and the general medical wards, which is a very positive reflection of the changes in, I think, in leadership and structure that have been made there. Similarly, very positive impact of critical care outreach on the St Helier site. That's coming through in the review processes. I think there is always more that can be done, and that those areas for further focus and attention are highlighted here. More around sepsis care, which is already a quality priority. More around how we assess patients who've got dementia and how we assess mental capacity. And also a specific issue around the quality and depth of attention which is put when people complete death certificates. And as a consequence of that, we've actually got a whole hospital cross-site training session on that a week on Tuesday, because we realise that the training our staff get in how to undertake a death certificate is actually not as robust as it should be. So we've put in some actions there. The tables which you'll see on underneath highlight the overall ratings of different areas of care from the first 24 hours through to ongoing care, end-of-life care. And you'll see the aggregate figure, which for quarter two, 3.7, which is a figure that gives assurance that adequate or good care is being given to the majority of patients. However, we've also got a sort of breakdown of the numbers of patients for whom the care was not adequate, good or excellent. And you'll see that for 2 patients, the care was deemed to be very poor, and for 9, poor. And to give information on what happens then, when the level of care is poor or very poor, that automatically triggers a DATIX report and a root cause analysis, which is then undertaken. So that's the process we're following. So that's the key messages from mortality reports. Concurrently, we obviously have our serious incident investigation process. And you will see here that in the period here, quarter two, if a case raises significant concerns about the quality of care provided, it would be converted to a serious incident. So we're looking for a triangulation of figures. And in the period July to September, 2 cases were reported where there was a potentially unexpected or potentially avoidable death. And they have been investigated through our SI process. And during the same period, 3 cases were completed. This report is here for information, and I'm very happy to take any specific questions that have emerged.
Thank you, Ruth. That's really helpful and comprehensive summary of it, and I'm really pleased to see the additional information that Quality Committee asked for. Any points that people wanted to raise?
I just wanted to welcome the training on the death certification, because I know that once the death is certified, you can't, or it's extremely difficult to change it. And this has been distressing for some families where it perhaps hasn't been accurate in the past, and that Lisa may know whether that's still the case, that we've had complaints about that. But I have certainly seen complaints in the past where it hasn't been accurate, so I really welcome that.
Thank you, Pat. Chris?
Thank you. Just in, in terms of a level 2 review, there's 3 categories there where specifically the death goes straight through to level 2. I was interested in the deaths of people with learning disabilities or severe mental illness. Is there any, do you look at the figures specifically by, well, in that group, see if there's any separate learning to be had from that group of patients, or is it very similar to everyone else?
So we look at it separately and we look at it together. I think if you look at some of the learning highlighted, it links into that. So I think one of the points highlighted under the learning section, paragraph 16, if I try and decode what was written, it's about diagnostic overshadowing. Yeah, so where it says dementia, mental health and learning difficulties, diagnostic overshadowing, what that really means is that we have identified that in some patients where there is a learning disability, that diagnosis or that underlying diagnosis has overshadowed the team's thought processes and thinking through the concurrent physical diagnoses. So that's been identified specifically through looking through those reviews, Chris, and we're working with the learning disability team and with our medics in order to address that. And we've actually done some grand round presentations on it to alert clinicians to what we have found through this process.
That's very good to hear. Thank you. Any other points? Can we note this report? Thank you. That takes us then to item 5.1 and the Responsible Officer Report to Board. Welcome, Martin. You've been very patient. Would you like to join? Is there somewhere where you can sit? Are you happy to stand?
Yes.
It doesn't seem very welcoming. The rest of us have all got seats. But you are very welcome. You are very welcome, Martin.
Okay, thank you, Chair. This is my final report as responsible officer to the board. I'd give you a very brief summary. The system of responsible officers to assure the quality of doctors working within designated bodies was set up essentially back in 2010 and came into effect in 2012. And I've served as the Trust's responsible officer since that time. I have now been replaced on my retirement from that role by Steve Helier, who's sorry that he can't be with us today to be introduced. During that time, every doctor who was originally employed by the Trust under our designated body on October the 1st, 2012, has been through the process, and all but one of those demonstrated their fitness to practice effectively. And we're now on our second cycle with people coming through, both new, newly appointed and newly registered doctors, but also those of us who've been through the process once are going through it the second time. It's all based around medical appraisal, which over the years we have strengthened to make it more useful and supportive in that for doctors. We have also had some instances where we've had to support doctors who were in difficulties. The report is as it is, so you've seen that, and I'm happy to take any questions on its content. For the future, I think the scanning the horizon, as it were, I think that there is an expectation that designated bodies will provide a greater standard set of information for individual doctors on their activity and any other aspects like complaints or investigations they may have contributed to, so that they can reflect upon those easily. And also that where doctors are in difficulty, there is a greater level of support for them as they go through that process, in the hope that, as is the case in the vast majority of cases, they can be brought back to a proper and useful level of practice. So it is particularly important that we do have the 2 points remaining from the higher level responsible officer visit, which is now 2 years ago, which is that there is adequate support for the administrative processes of that, which we're still a little short on, and also that we have probably best appraisal leads in each area so that the suite of information provided can be appropriate to their particular profession. We have quite a lot of information automatically on activity for surgical type specialties. Much more difficult to do that for physicians, paediatricians, ward-based doctors, anaesthetists. You know, their actual activity is quite difficult to record. So I ask the board to note the report and support the recommendations. And I'm happy to take any questions.
Thank you very much, Martin. Any questions for colleagues? Oh, James.
This has occurred in other fora, but I think it would be good for the board to acknowledge the amazing work that Martin has done over the years. It may not be apparent to all members of the board, but Martin is nationally recognised as an expert in the role of the responsible officer, which is increasingly complex. And I do hope that the country doesn't lose your skills and knowledge. And just speaking as a member of the medical profession within the trust, I know Martin has shown huge compassion and wisdom and support for doctors in difficulty, and I hope your successor carries on that good work.
Thank you, James. I'm sure the board would want to endorse that. I'm a very recent recruit to the board, but I already feel that I know Martin. I've spent time talking to him and seeing some of the work that he does, not particularly in this sphere, but in other spheres as well, and we will certainly miss all your contributions, Martin. Are there any other points, Pat?
Yes, well, I'd certainly, having worked with Martin, like to second James's remarks, but I did have a question as well. I just wondered, Martin, whether you could rate the risk of... There's a group of doctors who defer revalidation. They arrive with not having revalidated, and then move on to us and other trusts. I mean, is there a group of doctors who are doing that and not being captured by the system?
The systems that I put in place within this trust mean that we don't allow that situation to... I mean, there are some circumstances where it's inevitable. If a doctor is with us for 3 months, we won't have enough information to make a revalidation. They're a perfectly good doctor. If there were any concern, then we would raise that and escalate that as necessary, and certainly communicate it to any next employer. We also are concerned to make sure that they do, even if they're not with us for a full year, undertake some form of appraisal so they have something to carry forward to support their revalidation. This is assuming there is no concern about the doctor. And we are assiduous in going back to previous employers if that doctor is peripatetic and moving very frequently, which can sometimes be a slight red flag for risk. So it's part also of the employment process that the RO does get cited on the doctor's previous history, insofar as that is possible within employment law and the appointment process.
I think just to make one point, so I obviously hear the concerns raised here around the sort of administration support for appraisal, and given the increasing importance of appraisal, this will be taken through our business planning process, which is our process for allocating resource that is required in addition to our sort of established budget. And I think the anticipation would be it would taken through our business planning process in February of this year.
Thank you for that clarification, Ruth, which I think we'll have to add to our decision making. Aruna?
So really just following up on that in terms of remediation, as you've pointed out here, you know, one of the key things here is the investigations being completed more quickly, and as you pointed out, Gillian, that is a 20 risk at this point in our risk register, coupled with our appraisal rate not being where it needs to be. I think we need to give some consideration in terms of the impact it has in terms of doctors and revalidation and how accurate that is.
Well, the first thing to say is that our appraisal rate for medical appraisal for doctors is well within line with all other acute trusts, so doctors are somewhat ahead of that curve. However, it is certainly true that in common with many other organisations, in fact I'd say all other organisations investigating doctors, is a slow and somewhat bureaucratic process. We are constrained by the Department of Health guidance on that, which is called Managing High Professional Standards. And there is work going on nationally to try and see how that can be improved. There are also problems with the length of time internally, which we could certainly improve.
Thank you, Martin. So if there are no other points, I'm presuming, Martin, your successor will pick up the GMC view about further work to improve public and patient engagement.
Yes, indeed.
Thank you. So we're asked to accept your report, noting this will be shared with NHS England, and approve the statement of compliance. I won't read all of that out. And I think we're very happy to do that, subject to the point that Ruth made about the business case being made for the necessary improved support, which does come across strongly in your report. So on that basis, are we happy to accept the recommendation? Lovely, thank you. And Martin, very much your swan song. Thank you again for all you've done for the Trust. I'm sure we'll see you around, though.
Thank you.
Thank you. Right, we're a little bit behind, so I'm hoping we'll be able to make up a bit of time. 5.2, the update on the well-led action plan. Peter.
Thank you, Chair. So just a little bit of context. So it's good practice to have an external review of your sort of strategic governance, which we did back last spring. That resulted in 10 high-level broad recommendations, most of which we've now completed. There are a number that are still outstanding or in process, some of which we've covered off today or demonstrated. Start, for example, in the IPR, we're now using statistical process control charts, and we will do more of that. We've touched on, for example, we need to do more around quality improvement methodology and strategy, which we've alluded to earlier on in the board. So there are a number of areas where we are still making progress as opposed to fully complete. Our plan is to complete all of the items basically in the remainder of the year, apart from those which sort of make sense to lead into kind of ongoing action plans. For example, I know you're going to lead us through some board development work, which we will need to pick up as part of the wider, not just sort of board development, but wider organisational development, which Debbie's leading on. So really, this is a progress report to the board to note progress. So happy to take questions or comments on the specific actions, but really, this is the board just to kind of confirm that we are making the progress we said that we would do.
Thank you very much indeed, Peter. So, comments, questions? Stunned silence.
Lots of work.
It's very comprehensive, and I had the advantage of being able to see it earlier and ask some questions. So I don't, happily for all of you, I don't need to do that now. Is everyone else happy with this? So I do want to, given that there aren't any questions, I do want to thank the executive team for all they've done in this. I mean, bringing in external people to do a well-led review for you and then really embracing some of the recommendations is exactly what high-performing organisations do, and it is good to see how much of this is green. Still some ambers and a lot of it important stuff, but I think very good progress. So I think at this stage we note the progress.
Right.
Very happy to do that. And even better, we've caught up with some time. So 5.3 is the terms of reference review. Peter, over to you again.
So one of the actions in the well-led action plan was to review all the terms of reference and the governance structures, which we have done over the last few months. So the task here is really for basically the reporting committees to the board have reviewed their terms of reference and approved them. The job of the board is to basically to ratify those. Yes. And that's the purpose of this item.
The point you make in the report, does it feel right overall? Is
Yes.
there a kind of commonality? So how do people feel about this? Everyone happy? Yeah. So I think we're approving them.
Sorry, Chair.
Oh, I'm so sorry, Pat. It's because you're sitting along from me.
Yes,
I can't.
no, it's fine. I just wanted, it has been brought to my attention, and I was very grateful for that, that we ought to, if everyone is content to do so, amend one of the things in the PSQ one, which is under 6 membership. The list of people who might be invited to attend is required, that we should add in the Freedom to Speak Up Guardian and the Guardian for Safe Working, because they've become more central to our work, and we regularly do that, and it was an oversight, so I would ask people to accept that.
I think we'd all agree with that, Pat. So on that basis, can we agree the terms of reference? Thank you. So that takes us on to 5.4 on the summary report from the Audit Committee. Elizabeth.
Yes, thank you, Gillian. This is the meeting which we had on the 26th of November. And one of the things which we do at Audit Committee is that we receive a number of really quite detailed operational reports, which are then used in order to triangulate whether there are emerging issues within different parts of the Trust. And you can see that there is a brief note there about the salary overpayments report. Salary overpayments are not in money terms large or significant, but clearly it's an area that we need to keep in view, and it can also point to other problems potentially. So we asked for a follow-up on the work which on the number of overpayments in surgery division, and that was satisfactorily cleared. And you can see that there is a brief note about salary payments made to GPs in training. And we say in this report that it has been investigated and that we've closed it. That isn't actually the case. And I'd like to just assure you that we will be taking it as an agenda item at the next meeting, and Debbie, who's the executive lead, has agreed to come along to that meeting. The rest of the work which we covered, we spent a considerable amount of time talking to the external auditors about where we want them to focus their attention in their audit, which they'll be starting, or they start before the year end. There are 2 very, very big pieces of work which are going on at the moment. One is that every 5 years we are required to revalue all of our land and buildings. This has to be undertaken by external experts, and so the committee approved the appointment of the external people for that, and obviously KPMG will be auditing the results of that piece of work, but it is a 5-year requirement. The other new piece of work which will have to happen in this year's audit is obviously looking at the community work which we're now taking on. And I know that Rakesh and his team are having a number of conversations with the auditors as to what they will need to do in order to get their audit satisfaction. You will see in the note that we have talked about adopting something called IFRS 16. If you are an accountant, this is absolute catnip. We had a most wonderful conversation about it. But just to tell you, IFRS stands for International Financial Reporting Standard number 16. This is a framework which is mandatory for all large organizations across the entire globe. So if you are a large corporate in Australia, you have to apply IFRS 16. If you are, whoever you are, and we are within that same framework. All I would say to you is, if you want to find out more about it, you can Google it. But you might frequently, over the course of the next few months, years, hear Rakesh or me saying, well, before we need to consider this capital investment, we need to think about the IFRS 16 impact of it. It's quite a technical matter, but I'm happy to talk to anybody who'd like to know more about it. The other colleagues who were with us at the audit meeting were obviously our internal audit colleagues, who are making sure that the recommendations that they've raised in previous reports were followed up, and the counter-fraud people, because as we are a public sector organisation, we have a zero-tolerance approach to fraud. But there is nothing to report on that basis. Thank you, Gillian.
Thank you, Elizabeth. And I have to say, as a non-accountant, I'm delighted I have lots of accountants like you and Rakesh to worry about IFRS 16 and advise me accordingly. So, any points that colleagues wanted to raise? Martin.
Just on the salary overpayment, I guess there's two aspects to it. As you say, it's not significant from a trust point of view, but it's potentially significant from an individual's point of view. And in my experience, it's surprising perhaps, but very often people don't actually know that they've been overpaid. And then when you come to recover it, and I'm sure that we do, but we'll just ask for it to be a compassionate approach in terms of that recovery. The other thing is more a suggestion that perhaps we can follow up. A key metric that many organisations use is simply the percentage of people who were paid incorrectly each month. And that would be something that might be worth us looking at in pod, whether it's under or over. Thank you.
Yeah, you're absolutely right. The recovery is very, very important, because obviously we want to recover the money, but it can make a huge difference to people. And that is why on this aspect relating to the GPs in training, it's Debbie who is leading on the programme.
Okay, and in terms of overpayment, do we have a process, sorry, this is a detailed point, and it's probably a question for you, Rakesh, where we look at regularly the top 50 highly paid people, so that if there's been a mistake, it kind of pops up?
Yes, so we look at highly paid people for a number of reasons, not just us. But in terms of the payment thing, we do have our SFI say we reclaim any overpayment as a matter of course within 3 months. But we look on a case-by-case basis for the reasons, for compassionate reasons, and so yeah.
Okay, thank you. Are there any other questions of Elizabeth? Otherwise, can we note the report? Yes. Thank you very much. Takes us to 5.5 in the EPRR Annual Assurance Report. Sue.
Yes, thank you. So this is a report which summarises the progress and improvement made over the last 12 months in relation to our emergency preparedness, resilience and response. And just by way of explanation, this is relating to the way that we would respond to a major incident or a critical incident, or how we manage business continuity in the event of a system failure in the trust. Our plans developed in the context of the legal requirements of the Civil Contingencies Act of 2004 and the NHSE EPR framework and core standards. I'll just briefly summarise. We've got 64 standards that we were assessed against earlier this year, and we have measured positively against all of those. We met every single one of those standards, and that's an improvement since 2018, where I think 8 of the standards were amber, so much better performance. We've outlined in the report how we're managing our preparation for major incident or critical incident in terms of the planning that we do, the tests that we run, the simulations that we run, and what our priorities are for this year are detailed in section 12. So what we're asking to do for the board to do today is to note the progress that's been made, to support the priorities for next year, and to improve our declaration of compliance, which is in Appendix 1. Just one more point to note is there's a section on Brexit in there and our planning for Brexit. And yesterday we joined a conference call where nationally we were asked to step down our preparation for a no-deal Brexit. And so we were having to go into a series of reporting again in January because of the risk of a no-deal Brexit. They've asked us not to plan any calls, not to work on any no deal. They're expecting a deal to be achieved and for us to go into a period of transition between the end of January and December this year. So that's a change in the report. And happy to take any questions.
Thank you very much, Sue. Thank you. Any other points people wanted to raise?
What did I do again?
It's Pat. It's quite all right. That's the board.
Yes, indeed. It was just so it was just under the governance structure. I just have to flag up a concern about, you know, we write these things and we say that the Resilience Committee reports to the Trust Health and Safety Risk Committee, and that reports to PSQ. I don't really have any sight of the Resilience Committee, and I don't know what other trusts do. And bringing this to the board, obviously we all get sight of it, but I'm just slightly concerned that it looks as though we've got assurance through that pathway, and I don't feel that I personally, as chair of PSQ, have got any sight of it.
Yeah. Okay. That's a point well made.
Yeah.
Sue?
I think I'm happy to take that outside. Actually, I think it's been through CTM, and I think. Yeah, it's a valid point.
The whole point of having these discussions is to make sure that we get it
we
as
probably
right
need
as we can.
need to look at where it should sit.
Yeah, it may be that it needs to come to board via quality committee.
Yeah.
So yeah, we'll sort that out outside the board. Any other points? No. In that case, Sue very nicely summarised what the board's asked to do. It's on the front sheet of the paper. So, are we happy to agree those recommendations? Yes. Lovely. Thank you very much. That takes us to 5.6 and the use of the trust seal. Trevor?
Thanks, Chair. So, as previously, the board has approved the construction contract for a new ITU refurbishment at St Helier Hospital. The trust required for all contracts over £1 million to have a contract sealed. This was just ratifying that we actually have a contract in place for the construction works, and that the seal was used.
Lovely, thank you, Trevor. We're asked to note that report, and I'm sure that's agreed. And takes us to item 6, contracts awarded over 50,000. Rakesh.
Board's asked to note this report. The report's been to our Finance Committee, and it just details the contracts we've awarded over 50,000 during that period.
Okay, and again we're asked to note that. Is that agreed? Yep, great. It's lovely how we always catch up time towards the end. Item 7, any other business? Says she trying not to catch people's eyes. I have an aversion to any other business. Any other business item is for board members, sir? Not for members. Sandra, sorry. Not for members of the public. Perhaps I can talk to you at the end of the meeting.
I'd like to ask a question of the board, if I may.
I'm sorry, this is an any other business item.
Okay.
So it's not a public question time. Thank you. So the date of our next meeting is Friday the 13th of March, and we will be in St Helier on that occasion. And that brings us to the end of the board meeting. At the end of the board meeting, so the board meeting is closed, we take written questions in advance from members of the public. And we have a question from Councillor Liz Frost, who I think is in the audience. We have it in front of us, unless you want to. You don't need to read it out, do you, Councillor Frost?
No, and I'd just like to say thank you very much. It was a question about access to Wi-Fi rather than having a bag to use the papers here. Yes, I've managed it. So just thank you very much for making that facility available. Should save a lot of trees.
That's very kind, thank you. Peter, did you want, for the benefit of everybody else who won't understand what that exchange meant, can we just...
Sure. So Councillor Frost asked 2 points. One was making it easier for people to find our board papers on our website. So we've changed so that there's an easy link put on the front page of our website for that. And the second point is actually broader than just this meeting and this room, is there's basically free public Wi-Fi available on all NHS places now. So for other members who wish to look for it, if in your how you find Wi-Fi, it's called NHS Wi-Fi, that's the one to pick, and there's no logins required. You just click a few buttons and then you'll have got free NHS Wi-Fi. So those were the 2 points that Councillor Frost raised.
Excellent, thank you very much indeed, Peter. So that's the end of the formal part of both the meeting and the post-meeting, but Daniel and I think James and Ruth are going to stay behind to take any questions from the lady who's already indicated, and there's another gentleman there. So the rest of you can go and have your quick lunch break, and 4 of us will remain. Okay, thank you.
This is a new risk in Sydney.
Right, yeah. I mean, it's just we. I mean, we.